Hello and welcome to Grand Rounds. We're going to be talking about acne today, our favorite topic. I'm Hilary Baldwin from Brooklyn, New York, and today we're together with Shanna Miranti from Naples, Florida. Hi, Shanna.
Hi, so good to
I
see
can't
you.
wait to talk about acne.
So excited. It's one of our favorite subjects.
Yep. So I got a case for you.
Great.
A 35-year-old African-American woman who's experiencing her third relapse after isotretinoin.
Oh,
So she had two courses previously and cleared. I was her treating physician, so I can tell you she did have enough.
that
She
was
had,
going to be my first question. Did you
right?
treat
I knew
her?
it was.
Because
I beat you to it. Somewhere
did she
between
take a full
100,
5 months? Did she
yes,
have the right cumulative dose? Was she completely clear? You know the question.
exactly. 120 to 150, 2 months without a new zit, the whole 9 yards. And stayed clear for about 3 months. Did it again, stayed clear for about 3 months. So now she's again, she's 3 months past, and look at her, right
Ugh,
back to square one. We did a hormonal workup a couple of visits ago, and she was negative. So there's no overt hormonal drive for this to
smart,
continue to do this.
smart. Yeah. No
And she
PCOS, nothing crazy
no,
going on.
no. So she's interested in a third course. But this time she wants to try to be a little bit more proactive, uh, to do something to prevent another relapse. She
Ooh,
has very low blood pressure and she's afraid of spironolactone because frankly, that's what I usually do when
yes.
a female patient comes back having failed isotretinoin because she relapsed. I start spironolactone about 2 months before stopping the isotretinoin to try to keep the sebum reduction going. And I'm quite successful in that regard, but she didn't want to be on spironolactone.
I
So,
actually learned that Accutane hack from you in one of our previous discussions. I
oh,
love
did you?
doing that now as well, and
Yeah,
it's so effective. But I
it
can
is.
understand her, her nervousness at this point. This is a tricky case.
Yep. So what would you do?
So, given the fact that we can't use or not that we can't, but she doesn't want to go with oral spironolactone, toward the end of her course, I would certainly restart her on isotretinoin, because as we've discussed, there is no law that you can only give one course of isotretinoin or two courses of isotretinoin over a person's lifetime. So, I would certainly consider putting her on a third, considering how much scarring and PIH it looks like she's accumulating. But I would certainly, start low, go slow with it. She, of course, should also potentially be on something that can maybe block some of those androgens that are bringing back this acne with such force at 3 months post isotretinoin. So I love the idea here of certainly getting her started on good skincare, good sunblock while on isotretinoin. And then I like the idea of starting clascoterone BID while she's on her course of Accutane and make sure we get her all the way through to that. I would really push toward that 150 milligrams per kilogram.
Yeah.
If she's failed twice, I would try to go for the higher end of that cumulative dose range and then start a good topical retinoid that has data in our skin of color patients like tazarotene or triferritine at the very, toward the end of her course, if she can tolerate the dryness and irritation, to get ahead of that, hyperpigmentation and really start working on that as well. So I
Yep.
know that was a long answer, but I hope you
No,
understood my train of thought
it's a
there.
thorough answer, and that is exactly what I did. We started the isotretinoin again, because to your point, 5 courses, 6 courses, whatever the heck it takes. Sometimes I change things up a little bit and I go to low dose long term for that third course. But you have to know your patient and make sure that obviously birth control is well taken care of because
Yeah, I
35
was going
years
to ask,
old.
how do you feel about microdosing in a female? Are you
I
okay?
love microdosing, but I would way prefer for there to be an IUD or an implant. Because if we're
With you.
talking about a year and a half of low dose treatment, I'm not into condoms at that point. I want something more definitive than that.
Yeah,
Something that you can't forget. Because the data
correct.
shows us that adult women are no better than teenagers at
No.
taking their birth control. And I don't want to end up with a isotretinoin birth on my hands. So
Right.
that's what we did, and we succeeded. I honestly didn't know where it was going to end up. I wasn't sure that clascoterone was going to give me the same bang for my buck as spironolactone orally did. But 3 months later, she's still clear and my fingers are crossed because she never made it to 3 months before. So I'm hoping that this is going to be enough to suppress her sebum production. And I think you're right. I would at this point add certainly a topical retinoid. I didn't have a after picture. She didn't have any more hyperpigmentation that resolved as her lesions went away. So
Oh,
we
that's
didn't have to do it
fantastic.
for hyperpigmentation, but I think that would be a safe combination at this point.
Yeah, I love using tazarotene. And again, I know we've discussed this as well, but I always, start patients as they take their very last pill, the day of their last pill. I have traditionally started on tazarotene 0.45
Right.
percent. However, I like trifarotene here too because of all of the data that they have for skin of color and for scarring as well.
And hyperpigmentation.
And
I agree.
hyperpigmentation. Yeah, absolutely.
Okay, your
Okay,
turn. Stump
my
me.
turn. So let's go into a case of hormonal acne. Again, as we've discussed before, all
Ooh.
acne is hormonal. But this is a 21-year-old white female who complains about her hormonal acne because she says she only breaks out before her menstrual cycle. So she never really had acne as a teenager. She hit 2021 and all of a sudden started to have more of a cyclical pattern of her breakouts. She's currently using a hormonal IUD for birth control, which she believes has made her acne worse because it just happened to coincide with the insertion of this IUD. And a few months later, the acne started to progress. She really does not want to switch to oral contraceptives because she does not trust that she would remember them daily. She likes the idea of an IUD for contraception, but she doesn't want to really change at this point. So with this patient, what would you do?
So she doesn't want to switch to um oral birth control, but she also doesn't want to pull out the IUD.
Right, right. She wants to remain on an IUD, so she doesn't want to switch to potentially a lower, hormonal or a balanced hormonal birth control with the
Yeah.
estradiol and progesterone as well.
I've had this problem with patients actually with my own daughters as well. Um, both with the hormonal IUD, they'll kill me for saying this, but both with the hormonal IUD experiencing a flare of the acne that they haven't had for many, 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 many years. And that IUD really, in many of our patients, about 10-15% of patients with a hormonal IUD are going to have acne bad enough to warrant significant treatment. Frankly, that IUD should come out
Right.
and be replaced with something. But what are we going to replace it with if she doesn't want oral contraceptives? And her point is very well taken that that if she thinks she's going to forget, that's not a great method for her. So because she's got hormonal acne, because she's cycling, I would love to see her on a combination oral contraceptive, but that's not going to happen. So spironolactone would be my first choice, or spironolactone plus minus clascoterone as well to try to get her under control. So I would do spironolactone and triple combination, or clascoterone and the triple fixed combination.
I love where your head's at.
Mhm.
And I believe that's exactly kind of where we were headed. So we decided to do clascoterone twice daily and tazarotene 0.045 at night. So she really wanted, she understood that it was most likely coming from the IUD, as her elevation in acne certainly coincided with the timing of that. And even though it's supposedly such a less amount of systemic androgen activity, I have a number of patients that do definitely respond to those hormonal IUDs. And of course, we know there's multiple different levels of levogestrel in some of these IUDs, or there's even the copper non-hormonal IUD that patients can switch to. But I never really feel like I'm the one to give them that recommendation. I always send them back to their OBGYN to have that
Oh,
discussion with
absolutely.
them as well. I don't want to be the one saying, oh, well, my derm PA said I need the copper IUD.
Right.
So I just say there's a lot of options out there. Please go have a great conversation, with your OBGYN. But this patient definitely, was really not fond of systemics. She did not want to take oral contraceptives. She did not want to take oral spironolactone. I think that would have been a great option for her. She had a very nice result very quickly within a few months, and did have a nice resolution of the acne that was potentially driven by her androgens, and a nice resolution in some of her PIE, post-inflammatory erythema, as well.
So that was wonderful. As much as we can continue to talk about acne for the rest of the night, our time is up. So we are going to finish up. It's Hilary Baldwin here, Shanna Miranti. Thank you so much for playing with me tonight. And stay tuned for another episode of Grand Rounds.
Can't wait. Looking forward to it.